I have 4 cases tonight, and I'll present it to Dr. Park and Dr. Prasad. And this format is always, I think, interesting because you can see how the physicians kind of on the spot think through the cases. I'm going to ask them some questions about each of the cases, ask them, what they would do in each scenario, and get their thoughts there. And then I know these cases always result in kind of questions that come up. And so if you have questions, what I'd like to do is just save them to the end and answer the questions at the end. But we'll save a good chunk of time, 25 minutes or so at the end to do some Q&A. And the questions could be general questions about acoustic neuromas, or they can be questions specific to your case as well. Okay. So the panel tonight is Dr. David Park and Dr. Amit Prasad. And both of them specialize in surgery for tumors as well as radiosurgery for tumors. So they're adept at managing acoustic neuromas, both surgery and with radiosurgery. I'm going to give them a series of case presentations and then ask them to give us their thoughts on these cases. So without further ado, I'm going to start the cases. Okay, so Dr. Park and Dr. Prasad, this is your first case, a 51-year-old patient. It's actually a woman. She's got some right-sided hearing loss. It's been going on for about 3 years. Also got tinnitus on the right. But the reason why she's coming in now is that she's had some balance issues for the last year. And she actually says this is her worst symptom. She can kind of manage the hearing loss and the tinnitus, but the balance is really impacting her quality of life, and her facial function is normal. Okay, so Dr. Prasad, how, in terms of, there's no trick question here, so it's acoustic neuroma that we're going to talk about. Hearing loss and tinnitus, are they fairly common with acoustic neuromas?
Yeah, definitely.
Okay, what about imbalance issues?
It's common. It's a little bit less common than the other two. Can come from the nerve, but often from brainstem mass effect with larger tumors.
Okay, so how often is balance the kind of the symptom that is in this case the worst symptom?
Stratifying by size. In smaller tumors, it's almost never the worst symptom. In larger tumors, like 3 centimeters plus, probably like 60% of the time.
Okay. So in this case, I mean, every kind of presentation is got a little bit its own individual quirks, but in this case, kind of the balance issue in this patient was the one that kind of really brought the patient in. So Dr. Park, I want you to first describe for the group here what you see. And again, I'm not trying to trick you. I put up the most appropriate pictures here.
Yeah, so we can see like this is the T1 contrast image of MRI image, and we can see the round oval, well described, like well demarked shape of tumor on the left cerebellopontine angle, which is giving some pressure on the brainstem as well, and also filling into the canal. The internal acoustic canal.
Okay, what's this side? What's the other picture? You kind of described this picture on the left.
So yeah, the left side, I mean, the left image is the cross section, so axial image, and the right side, you can see the coronal image. So basically you're watching from the front, and you can see that mass is like basically covering the posterior fossa from all the way up to the tentorium, and still, like, as I mentioned, giving the pressure on the brainstem side.
Okay, so when most of you get an MRI report that talks about your acoustic neuroma, you'll often see 3 different numbers, and usually that's kind of an X coordinate, a Y coordinate, and a Z coordinate. So we're looking at the left side. The long axis here is typically the first number. The perpendicular is the second number, and the third number is this vertical measurement here. So sometimes if the radiologists aren't trying to be as thorough, they'll just give you two dimensions, and that's looking at this axial here. So Dr. Prasad, what size is this approximately? What would you know?
I'd call it mid-size, and I guess that the tumor is probably at most 2 centimeters in the cross-sectional diameters and maybe 3 centimeters in its vertical dimension.
Okay, so is that tiny, small, medium, large, huge? What?
Medium.
Medium. Okay. And Dr. Park talked about mass effect on the brainstem. So this is the brainstem right here, this gray structure. What are you looking for, Dr. Prasad, in terms of determining whether there's mass effect on the brain or pressure on the brain?
So you expect the brainstem to be sitting symmetrically positioned in the middle of the space between the two nerves where it's sitting. And it's over a little bit towards the right side with a little bit of a CSF gap on the left side, which indicates that there's some pressure pushing it off to the one side. The other thing is that there's almost like a scoop-like shape between the tumor and the brainstem, indicating that it's pushing physically the brainstem tissue out of the way.
Okay. So what Dr. Prasad said is, I don't know if the people in the audience can appreciate, there's some darker gray material here. That's actually fluid. And the amount of fluid on this side of the brain is wider than the fluid on the other side of the brain. And that's because the tumor is pushing the brainstem over. Dr. Prasad, how much can the brain tolerate being pushed?
Depends on the location of the brain. For the brainstem, not much.
Okay.
Maybe a couple of.
So the brain can scooch out of the way a little bit, but at some point it runs out of its ability to move over without a problem. And in something like this, where we see some pressure on the brain, this could be in this patient has symptoms. We know the hearing loss and the tinnitus and the balance issue, but in other patients, you can have this much displacement and have completely no symptoms at all. Okay, Dr. Park, patient is in your clinic, and again, came in mainly because of the balance issue. She said the balance issue is affecting her quality of life. What's your recommendation to the patient and why?
I think based on the size and the symptom, I would recommend surgery as a first step, because I mean, the symptom seems to be related to this tumor causing pressure to the brainstem and the cerebellum. So I think the first step we should achieve will be basically like at least minimal, at least like decompression of the tumor to relieve the pressure there, and that may benefit the patient's symptom.
Okay, so you think surgery gives a better chance of fixing the balance issue? Is that what you're saying?
Yeah.
Okay. Dr. Prasad, what's your recommendation and why?
I agree with Dr. Park. I would recommend surgery in this case because the symptom tolerance seems to be low. It's affecting quality of life, and doing radiosurgery, I think, has a good chance with this size of tumor of stopping further growth, but based on the location, has a poor chance of actually resolving the symptoms, whereas surgery would take the mass effect off the brainstem and has a much higher chance of actually resolving the symptoms.
Okay, so you're saying this is still within the size criteria for radiosurgery. Is that correct? Okay, yes. But you're just saying based on the constellation of symptoms that your recommendation is surgery.
Yeah, if this patient was asymptomatic, I probably would lean towards radiosurgery even at this size.
Okay. So what if this patient says, I don't like surgery, I want radiosurgery? How would you counsel them?
I would caution them. This is not something that would be unreasonable to treat with radiosurgery at all, but I would caution them that their chance of having their vertigo and imbalance and dizziness actually treated by doing radiosurgery is statistically much lower than by taking the tumor out. So, I mean, complication avoidance is a reasonable approach, and radiosurgery has a lower complication rate. But if the patient came because there's dizziness and vertigo, then we're not necessarily going to be addressing that problem by doing radiosurgery. That's how I would caution the patient.
Okay. Dr. Park, why does I take it you agree or disagree with Dr. Prasad?
I agree. I think radiosurgery is still an option, but I would really dig into the reason why the patient refused for surgery. So if the patient is just just worried about surgery itself, then I would say like basically the benefit and the risk of surgery dig into more details about that, because radiosurgery may not really improve improve the patient's imbalance issue, but also can actually make it worse. So, and also the other topic can be about the facial nerve preservation, because if the patient says, I'm really worried about facial palsy, and I heard about the surgery can cause significant facial palsy, then I may suggest some other options, which could be like combination of the surgery and radiosurgery for this case.
Okay. So, Dr. Prasad, this is the same patient. It's a what we call a Fiesta sequence on the MRI scan. And I want to ask you about some structures on this sequence. Okay. So this is a Fiesta sequence. It's not a contrast sequence. So the tumor is this gray shadow here that I'm pointing to with the arrow. And you can see it, this kind of white line here is where it's indenting the brainstem. And the tumor you can see where the gray turns to black right about out here. So what is this structure here, this white?
So that's the cochlea.
What does the cochlea do?
Responsible for processing of hearing information and transmission through the vestibular nerve.
So the edge of the tumor here gets pretty close to the cochlea. Is that correct?
Pretty close, but there's still a bone window separating it.
Okay, so a few millimeters of bone in there, right? What's this white structure here?
Semicircular canal.
What is that involved with?
Balance processing.
Okay. So I put this in here to show kind of the audience how the structures of the brain that control hearing and balance can often be pretty close to the margins of the tumor. In this case, there's only a few millimeter of bone gap that separates the tumor from the cochlea, the hearing center, and the semicircular canals. So if you look out here to the right side, there's no tumor. So all the white is the water and the fluid, but you can see a number of gray lines running through the water. Those are actually the nerves that are coming out to go to the cochlea and the semicircular canal. So the vestibular nerves, the hearing nerves, the facial nerves are all these little black lines running through here. You can't see them on the side of the tumor because the tumor is kind of covering them up. But on the correct sequences, you can break out the individual nerves and see things. So Dr. Park, so we know the cochlea is involved because kind of the hearing center or the brain where the hearing cells live. How does, with surgery, you remove the tumor, you don't get into the cochlea, right? But with radiation, what is the issue with radiation and the cochlea that we always be careful and be concerned about when we do the radiation?
So basically, when we give the radiation to the tumor, and we are talking about radiosurgery, there's a steep fall off of the radiation dose on the margin of the tumor, but still that means, although it's steep, it's not zero. So there are some spillage of radiation to the surrounding structure. So when we plan for the radiosurgery for that size of tumor, still the spillage of that of radiation to the surrounding structures are quite significant. So we'll have a decent amount of radiation going to the cochlea, which can damage the hearing. But for this case, the patient already has a hearing impairment, so I think that's not a big concern.
So Dr. Park's corrected that, when we do radiation for acoustic neuromas, one of the things we keep track of is the dose of radiation that the cochlea is receiving. And we have some rough parameters as to, what level we want to keep that radiation below. So it's impossible to treat the acoustic neuroma with zero radiation to cochlea. There's always going to be some that gets out there, but we try to minimize it as much as possible to maximize hearing. Okay. So Dr. Prasad, the same patient, you mentioned that there was compression of the brainstem by this acoustic neuroma tumor. So what features do we look for in the brainstem that would indicate the compression was significant versus, minimal.
So, I mean, the most important thing to look for is so you're on the T2 image, which shows water as being bright, is edema. So edema in the brainstem can indicate that the brainstem is being affected and is inflamed and irritated. There's maybe a little bit, there's not a huge amount of edema here, but there's maybe a little bit of edema immediately surrounding the tumor. The other thing to look for is whether there's a CSF cleft, like if there's a continuation of bright fluid between the tumor and the brainstem, and there is not, which indicates that the tumor is in close contact with the brainstem and not being separated by a normal cleft.
Okay. Okay. This is last image of the patient, Dr. Prasad. This is the upper image toward the top of the tumor. And if this patient, they didn't have it in the list of symptoms I gave you, but let's say this patient complained of sharp face pain on the left side. Would that be explainable by the tumor?
Yeah, the tumor comes towards the top of the posterior fossa near the tentorium, and the cut that you're showing me, although it's not clearly visualized because of the type of sequence, is about level with where the trigeminal nerve would exit the brainstem. Trigeminal nerve supplies sensation to the face, and we know causing pressure to it causes shooting pain to the face. So it would be, I think, within the realm of reality for this tumor to cause that problem.
Is it a common symptom to have face pain with acoustic neuroma?
It's not super common, but it's a known symptom.
Yeah. So about 5% of patients can present with some sort of either pain or sensory issue with acoustic neuromas, even though that's not the nerve for which the tumor arises from. Okay, so this patient chose surgery because the patient thought it was the best chance of addressing her balance issue. Her hearing was very poor prior to surgery, almost non-existent. So she had a trans-lab surgical approach. Dr. Prasad, what is a trans-lab surgical approach?
The translab is short for translabyrinthine, which refers to the labyrinth, which is the bony structures that make up the inner ear. So that includes the semicircular canals and the cochlea, like we were talking about. So a translab approach is going through the bony labyrinth, sparing the semicircular canals to preserve the balance, and sort of taking away the rest of the bone to go directly down to the canal where the tumor starts and to expose the part of the brain where the tumor is most present. The ENT surgeons help us with that.
Okay, well, and what happens to hearing with the translab approach?
It's not a hearing sparing approach, so patients don't have hearing after doing the surgery.
Okay, so you would use it in which patients surgically?
Patients who don't have serviceable hearing.
Okay, so if they had good hearing, what would?
I would err towards a retrosigmoidal craniotomy, which is able to spare the hearing.
Okay. Okay, Dr. Park, second patient. This is a 51-year-old male. He's got a little bit more than 4 years of balance issues again, and he says he's got to really concentrate on his walking. He focuses on his walking, he's okay. If he tries to talk on the cell phone, or if he gets distracted by some other thoughts, and then that's when he gets balance issues. He's got tinnitus on the left side, but despite all those symptoms, the walking issue and the tinnitus, he did not get any scans. Recently, a few weeks ago, he had a syncopal episode, and this led to an MRI scan. So, Dr. Park, what's a syncopal episode?
Basically, fainting. It's gonna be like being unconscious, but not like a seizure attack, and it's gonna be it's simply like fainting.
Yeah, so again, maybe lightheaded and then fainting episode. So interestingly, he's got imbalance for 4 years, but doesn't seem to want to get an MRI scan for that. But then he has one fainting episode, and they throw him in the MRI scanner. Okay, so this is what he's got. I want Dr. Park, describe what you see here.
So there's a heterogeneously enhancing tumor on the left.
What does heterogeneous mean?
So it's like irregularly showing signal. So it's like bright and dark all mixed up together in the tumor. Mm-hmm. So the contrast basically shows it goes like the paint through the bloodstream, and it shows bright color in the MRI. So some portion of the tumor is really bright. That means like there's like a higher blood supply there, and also there's a mixture of like a dark portion, which could be a cystic portion of the tumor. Yeah.
Okay.
And that. Mm-hmm.
Okay, so you're saying the bright white areas, maybe some solid tumor tissue, And then the gray areas are little cyst pockets in the tumor.
Yeah, could be.
Okay. So this is a cystic acoustic neuroma then?
Yeah, I would say,
Okay.
yeah, it's not like purely cystic, but like mixed.
Mixed. Okay. Dr.
Yep.
Prasad, what percentage of acoustic neuromas have cysts in them?
A good proportion, probably 50%.
Yeah. Okay. So I would say somewhere between 25 and 50%. And what so if your tumor has a cyst in it, what kind of additional thought process goes through your mind if you see someone with a cystic acoustic neuroma
So when patients,
in terms of like maybe change in size or things like that?
so both in terms of change of size and response to treatment come to mind. In terms of change of size, the cystic portion grows as well as the tumors usually grow by having the cells divide, but in tumors with cysts, they also grow by having the cyst fluid being secreted. So these can grow much faster in shorter intervals than tumors without cysts. And so patients can decline with tumors like this. And then in terms of treatment response, the purely solid tumors seem to respond better to stereotactic radiosurgery. Not that that's really an option in this case because of the size, but it predisposes towards surgery much more when patients have a substantial cystic portion to the tumor.
For both Dr. Parker and Dr. Prasad, any thoughts in terms of what causes the cysts? Like why does the guy just have bad luck, or what would make the cysts happen?
My understanding is that the cysts come from when the tumor is more large. Like many tumors, it starts to outspeed its blood supply and parts of the tumor die, and then the normal fluid that gets released by those cells collects in the part of the tumor that's died.
Mm-hmm. Okay. So, Dr. Park, what's your recommendation for this? Oh, well, first of all, Dr. Park, what would you estimate the size of this acoustic neuroma to be?
I would say like in the maximum diameter, I think it's nearly like 5 centimeter. Yeah.
So is that
it's a
small,
large,
medium, large?
a large adenoma.
Okay. What do you recommend?
I would recommend surgery.
Um,
Yeah, the first step. I think, I think the cystic nature really could explain the patient's symptom in some way. So I think the tumor itself was, growing exponentially, and that's the reason why the patient could not adapt to the size of tumor and had this, syncope maybe.
Okay. So let's talk about the surgery. How long a surgery is this?
Let's say like maybe like 8 hours minimum. 6 to 8 hours minimum.
Okay. What's the risk to hearing and what's the risk to the facial nerve with the surgery?
So for hearing, those are all high risk. Basically, it's going to be very difficult to preserve hearing for this tumor. For facial, it depends on the extent of surgical resection. So and also whether you use neuromonitoring system during surgery, but still the chance of facial palsy is still quite high. I would say about 20 to 30%.
Okay. Are those risks are a function of the size of the tumor? Is that correct? So you're giving numbers for a tumor this size.
Mm-hmm.
Okay. What going back to that first tumor that was smaller, what would be the risk of facial injury with surgery for something that size?
I would say probably about 10% or less.
Okay. So so the risk to the facial nerve is clearly a function of the size of the tumor. And we know that from a lot of the medical literature. So what are your goals of the surgery here?
I would say debulk the tumor, decompress the tumor, the mass effect, and get pathology, and also preserve the functions as much as possible.
Dr. Prasad, your thoughts on treatment?
I agree that radiosurgery is not an option here because of the size and the compression. So surgery is the treatment of choice. And then in terms of goals of surgery, I agree with what Dr. Park said. The goal number one of surgery is to decompress the brainstem and hopefully prevent hydrocephalus because it looks like the drainage system is already compressed. So I mean, the patient may already have hydrocephalus, but that's certainly something to look out for as well. And
What is hydrocephalus?
hydrocephalus, so the brain has a natural fluid system that circulates through it. And where Dr. Chang was just pointing with his pointer is a structure called the aqueduct, and then lower down the fourth ventricle. And for the spinal fluid that's made by the brain to empty out of the ventricle, which are like the fluid bags in the middle of the brain, they need to go through the whole thing and empty out the bottom. So when that pathway gets blocked, the fluid just piles up and blows up the ventricles, which are like Ziploc bags in the top part of the brain, and they cause the brain to be compressed. And they can cause a lot of thinking dysfunction and walking dysfunction.
Okay. This is a different view. Any comments on this, Dr. Prasad?
Yeah, I mean, it confirms what we thought before. There's a lot of brain stem mass effect, but it also demonstrates sort of in terms of the vertical position of the tumor. This is a very high-oriented tumor that really sticks to the top of the tentorium, and is actually widest sort of in the angle of the tentorium. It doesn't go all the way down to the bottom of the brain at foramen magnum. So what's most important in this case is like in terms of surgical approach, is a nice wide corridor with access to dissect along the tentorium and get to the sort of meatier part of the tumor more medially.
Okay, so patient really, really wants radiosurgery though.
No way. I tell the patient that we'd hurt them with radiosurgery. Radiosurgery will cause some swelling due to the death of the cells and irritation of the brain, and the brain stem's already squished. There's a chance the patient could become comatose from doing that.
Okay. So this patient had surgery because it thought best chance of removing pressure on the brain, exactly what you guys talked about. Okay, case number 3. So 35-year-old woman, she's got moderate hearing loss on the left side, but she's got pretty functional hearing there. She can talk on the phone on that side. She's got some dizziness and tinnitus, seems to come and go. She claims she has some, it's hard for her to describe it, some visual issues, maybe some flashing lights every once in a while, some speckles, but they're pretty inconsistent, and they're not that frequent, but she can't really detect when they come on, and her facial function is normal. So, Dr. Park, I got 2 pictures here for you, okay?
Yep.
The first picture on the left is from February of 2023, and the picture on the right is from November of 2023. So what do you see here, and what are your thoughts between these 2 pictures?
So you can see the irregularly shaped tumor, solid tumor, like homogeneously contrast enhancing tumor on the left cerebellopontine angle, which consists of, I mean, it looks like a left vestibular schwannoma, of course. And from the dates, so it has grown like significantly, super fast, because I think in diameter it could be like from like 2 centimeter to almost like 3 centimeter, but like the volumetrically it grown like super fast over how many months? It's like
9 months.
9 months is it is quite unusual to see this dramatic growth.
Okay, so the radiologist comes back from lunch and measures everything for you and says it's 9 millimeters bigger on the long dimension. So long dimension is, the dimension from the internal auditory canal is 9 millimeters bigger than it was back in February. So it's 9 millimeters in 9 months. Is that faster than average, slower than average, or about average for an acoustic neuroma?
I think that is faster than average, and especially in this size. I mean, I think the base size matters a lot, because if it was super small and grow like 9 millimeter, the volumetrically it didn't grow that much. But like, I mean, it's still a lot, but like compared to this size, it has grown a lot, considering the
Dr. Prasad, what's the average annual change in size of acoustic neuroma? Like what would you consider like a normal range?
Not more than a couple of millimeters a year.
So you think 9 is a lot?
9's a lot.
Okay. What's this structure here?
the fourth ventricle.
And then what's happened to it?
It's quite compressed by the increase in size of the tumor.
Okay. So so what are you gonna counsel this patient then, Dr. Prasad?
Well, so I mean, usually when we discuss the options for this type of tumor, we will talk through observation versus radiosurgery versus surgery. Because of the behavior of this tumor with it increasing so rapidly, I don't think observation is really an appropriate option anymore. So I'd counsel the patient that we need to do something. In terms of deciding between radiosurgery and surgery, there's two factors that predispose me towards surgery in this case. One is that now there's quite a bit of pressure on the brainstem and actually effacement, like compression of the fourth ventricle. So I think with radiosurgery, A, it takes about 2 years for the cells to die, and B, it may cause some swelling. So we may end up throwing the patient into hydrocephalus over the next couple of years by sort of doing a more delayed action treatment. And B, the patient also had mentioned some symptoms like one of the earlier patients about imbalance and vertigo. And based on the tolerance of those symptoms, that would be something that would be better treated with surgery as well.
Now, you remember she talked about some funny flashing lights in the eyes. Is that related to this or not?
I don't think so. The visual processing system is all above this in the occipital lobe and in the thalamus.
Okay, so some unrelated cause of that then.
Get her to see a neurologist or an ophthalmologist to see what they think of that, I think. But
Okay.
not related, I don't think, to this tumor. Unlikely.
Okay. The patient says, well, I'm scared of surgery.
Yeah, I mean, I would talk her through the risks of both things. Surgery is, especially brain surgery, is certainly a daunting thing, but overall, the rates of complication with this type of surgery in experienced hands are overall, with this size of tumor, going for not being too terribly aggressive on the facial nerve itself. I'd say 10 to 15%, maybe 20 at most, risk to the facial nerve. Very, very minimal risk of stroke or other complication, maybe a 2 to 3% chance of CSF leak or associated skin wound related complications. So overall, 20% or less risk profile. And I think doing radiosurgery for this with the already present defacement of the ventricle, as I mentioned earlier, overall probably carries a not dissimilar risk, but of rapid deterioration. So I would still counsel in the direction of surgery, but just talking through the risks very carefully.
Dr. Park, your treatment recommendation?
Yeah, I also agree with it. Especially because of the risk of hydrocephalus, I would choose surgical option for him, for the patient. Yeah.
Okay. So what if the patient says, I don't want surgery?
In that case, like if there's, like, I mean, if the patient strongly insists, then the other option can be fractionated radiosurgery. Although there are like decent amount of risk for that.
Okay. So this is same patient higher up. This is another Fiesta sequence. What's this, Dr. Park? What's this black structure here?
Seems like that's trigeminal nerve or
And what's this stuff here?
the whole tumor giving pressure on that nerve.
So if this patient fair game to have facial pain then?
Yeah, definitely.
Because it's pushing on the trigeminal nerve, you're saying?
Yeah.
Okay. So this patient did not have facial pain. So it just goes to show you that you can have tumors pushing on structures and it can be completely symptomatic. Asymptomatic or not symptomatic. So, but you can clearly see how this tumor is pushing the normal structures away from the wall of the skull. That's why there's much more white fluid on this side. And you can see the fourth ventricle here, which should be almost like a circle, is being squashed over to that side. Okay, this patient chose radiosurgery because she was super anxious about surgery and she lives outside the US and didn't want to have to deal with any of the post-operative kind of follow-up. So far she's actually been doing well with the radiosurgery. Okay, last patient, Dr. Park. So he's a 76-year-old male. He's got several episodes of motion sickness, like when he rides in a car long distance. He's got normal balance, normal hearing, normal facial function. Okay, so if it wasn't for getting motion sickness, he wouldn't have ever come in. and got a scan. So he's got this guy here. What do you see?
So you can see the right, homogeneously enhancing tumor on the right cerebellopontine angle. The mass effect itself is really minimal, although it looks like almost touching, but I can see the CSF gap between that. So probably just near the brainstem and not really causing like pressure on top of it. Yeah, and it's
Okay.
Mhm.
So normal hearing, no tinnitus, no balance issues, normal facial function. What's your recommendation? 76-year-old male.
I think this is really quite debatable, but I would recommend radiosurgery for this patient because like
And
this
why?
basically asymptomatic, other than the motion sickness, and there's usually so we give some grading and for Coos grade like 1 or 2, like so if the tumor is not really touching the brainstem or really giving the pressure onto the brainstem, giving radiosurgery is has shown really good outcome on tumor control. So I would do that. Yeah.
What if he asks about observation? Can you just watch this? What are the risks of doing that?
I think that is also a good option. Considering his age, yeah, 76 and that size. Yeah, the risk is basically like tumor getting bigger and giving issue, and at that point, the radiosurgery option may not be applicable. So, um, I would rather recommend radiosurgery because that there's no like the risk is still low and the benefit is still high, and compared to observation. Yeah.
Dr. Prasad, your recommendation?
I agree with Dr. Park. I don't think it's wrong necessarily to go for surgery, but I think this is a very good candidate for stereotactic radiosurgery with a good space between the tumor and the brainstem. And despite the fact that there's a couple of symptoms, no symptoms that I would guarantee would be fixed by doing a surgery. In addition, you specified that there's good hearing still, and especially with the CyberKnife being able to give fractionated radiosurgery to this lesion, I think we have a much higher chance of preserving hearing by doing radiosurgery. And in terms of observation versus radiosurgery, it's a good question. The recent VREX trial, which came out in JAMA, didn't show much in the way of functional differences between radiosurgery versus observation, but what it did show is that it prevents further tumor growth pretty reliably doing radiosurgery. And this is it's a small medium tumor, but it's not a small tumor, like a medium small tumor. And so if this was to grow more and cause him more troubles, then treating it might become complicated if it starts to push on the brainstem. So I think this is a good, like a sitting duck for radiosurgery.
Okay. Observation then is you
Uh,
wouldn't recommend that or
perfectly, perfectly reasonable, but not what my upfront recommendation would be. But if the patient didn't want to do anything, I wouldn't caution him against it. I think it's perfectly reasonable.
okay. If he chooses to observe this, when would you get your next scan?
Do I have any previous scans that
Oh,
show?
no,
Okay,
this
so
is pretty, I mean, he's got motion sickness a couple times riding in a car. That's it.
yeah, fair enough. So he's got a symptom and he doesn't have a previously documented growth rate. So I'd probably get the next scan in 6 months and then move from there.
Okay. So this is a Fiesta sequence again. So here's your 2 minutes around ball right there. And then what's this white stuff out here?
That's the CSF in the internal auditory canal. You can see the nerve there if you squint really close as well.
Right. Okay. And so this tumor ends here.
Uh, yeah, looks like it. Yeah.
So what's the distance between this tumor and this and the patient's cochlea?
Probably about a centimeter or just below that.
Yeah. So is that a lot or a little?
In neurosurgical and radiosurgical terms, it's a lot.
Yeah. So compared to the first patient where we looked at where the tumor came all the way up to this, the tip here, the fundus, this one has at least a pretty big gap here, right?
Yeah.
Okay. So that would help you or hurt you with radiosurgery.
It helps. It helps with trying to preserve hearing more because you get less dose going to the cochlea. We can do a much better job of keeping radiation away from the cochlea.
Okay. So Dr. Prasad recommends radiosurgery. Dr. Park recommends radiosurgery. Let's see what the patient did. Okay, they chose radiosurgery because of the age and the paucity of symptoms. So what I want to do now is those are the cases I want to present. I wanted to use them as kind of a jumping off this Q&A. So